Hello everyone, this is Dr. Satish Pawar, Chief Surgical Oncologist, Care Hospitals, Hyderabad. I am here to talk about gastric cancer or otherwise called as stomach cancers. So, stomach is a part of the intestine in between food pipe and the small intestines. So, this is the part where majority of the digestion occurs in the initial part, and this, after we eat the food, it slips down the food pipe, and for around 2 to 3 hours the food stays there and slowly gets digested there because of the acid which is secreted by the stomach. So what happens really is, due to varied food habits or the addictions, there are chances that the lining, the inner mucosal lining of the stomach might have changes in it and subsequently may have something called cancer developing in it. So stomach generally has different parts to it. It extends from the gastroesophageal junction, that is the junction of the food pipe with the stomach, and then goes down to form the body, and then down towards, that is the end part of the stomach, that is called the antrum of the stomach. So we commonly see cancers in our region most often in the lower part, that is the antral part of the stomach. And otherwise we also see cancers in the body of the stomach proper or at the gastroesophageal junction. So there are various causes which are related to the different types of cancers which occur commonly in the stomach. So the general symptoms really are vague symptoms most of the times. They are very rarely patient presents with pain in the stomach, or in an advanced stage they present with blood vomitings, or say for example if the cancer grows to a size or to an extent that it completely obstructs the outlet of the stomach, that is called a gastric outlet obstruction. So these are the symptoms. They have continuous vomitings. They cannot, intake comes down drastically. They cannot even have liquids. So that is when a patient develops a gastric outlet obstruction and he tries to vomit out everything possible. So most of the stomach cancers symptoms, we cannot catch these cancers at an early stage because most of them do not have any symptoms at an early stage. But say for example you are a patient of acid reflux disease, or we commonly call it as acidity. So you should be very careful if you're not being treated. You generally antacids are available these days. It's in a rampant use of antacids we see. So if for example you go to a doctor, your general practitioner, he prescribes certain days of antacids to you and still the symptoms do not reduce, then you should be careful and go to an endoscopist or a medical gastroenterologist, or say for example in a smaller town a surgeon does an endoscopy, you go to them and get an endoscopy done, that is the upper GI endoscopy it is called, and you get an endoscopy done and visualize your food pipe as well as the stomach. So that is where you can easily diagnose a case of stomach cancer with an endoscopy, and subsequently if the area of the ulcer, generally it starts with an ulcer and it might have a growth there, and if you do a biopsy and we can know that a person has a cancer. So what are the risk factors of getting these type of cancers? So smoked non-vegetarian food, that is smoked fish, which commonly is consumed in countries like Japan and Korea. So all in our country per se, particularly having a lot of pickles or over fried or double fried foods. So for example, in this part, that is the South India, they commonly have this mirchi bhajia, which is commonly fried twice, and you keep the oil there for a longer time, and you reuse the same oil again and again. That is when you tend to these people tend to have this type of cancer. So it's a risk factor as such. And apart from that, you have smoking. Smoking in combination with alcohol again is dangerous. And apart from that, there's one more common cause, that is the H. pylori, that is the Helicobacter pylori bacteria, which is responsible for changes that occur in your stomach. So there is a simple treatment for this Helicobacter pylori. You would get an endoscopy done, and you send a rapid test for a Helicobacter pylori, and it is positive. You undergo a course of treatment for 2 to 3 weeks, and you might get rid of this bacteria. But in case you ignore and this lasts for longer, and you tend to this Helicobacter pylori might be responsible for developing a growth or a cancer in your stomach. So most often not, we see advanced nature of gastric cancers, that is, it starts from the inner lining, that is the mucosa, and extends into the muscle layer, and then comes out through the serosa, and it infiltrates all over the abdomen by tiny nodules. So typically, what are the tests recommended to detect a cancer? So as I have told you earlier, that's an endoscopy, which the scope, that a camera is put through your mouth, and then your foot pipe is visualized and your stomach is visualized, and you subsequently at the same time, if you feel a suspicious ulcer there, you take a biopsy, and that is when the story starts. Apart from that, how do you know that this disease, the cancer, which starts somewhere and spreads to the other parts of the organs or other parts of the body? So you typically you get a CT scan done, and that is not a plain scan. You do a contrast enhanced CT scan of the abdomen and the chest, or you go for a whole body PET CT in many cases, in most of the cases, and you stage the disease. But this scan cannot detect smaller nodules which spread out into the lining of your whole of the abdomen, that is called peritoneum. So what typically again is done is put in a diagnostic laparoscope, and many times we see that 50% of the advanced cancers will have smaller miliary deposits in the all over the peritoneum, that is the covering of the abdomen. This is seen more often than not, and then subsequently the whole treatment process changes. So again, till here it is the diagnostic, that is the staging of the disease which we routinely follow, and then treatment, once it comes to the treatment aspect, treatment for stomach cancers, be it in the lower part of the stomach, that is the antrum, or the body, or the gastroesophageal junction, main part of the treatment is the surgery. So surgery means taking out the affected part with certain margins and do a lymph node clearance. So once this is done, we reconnect the remaining part of the stomach or remaining part of the food pipe to the small intestine, and that is where the processed food again can come down into the small intestine. So in case we are not able to do a complete resection, complete removal of the affected part of the stomach, we do something called a bypass procedure. That is, we bypass the part of the affected stomach, put in a small intestine there, we join that part to the stomach per se, which is normal, and then food can get digested through that part and come to the small intestine. In case this is also not possible, then we put in a smaller pipe for feeding, that is called feeding jejunostomy. So this is the typical procedure which is commonly done in stomach cancer. But When it is at an advanced stage, when detected on a CT scan or a PET scan, we typically treat the patient with neoadjuvant chemotherapy in the distal parts of the stomach and reduce the size of the lesion. We give 3 to 4 cycles and then reduce the size of the lesion, and then subsequently take up for surgery and complete the rest of the cycles of chemotherapy after the surgery. This is one kind of protocol, and now with newer drugs and newer protocols, there's a regimen called FLOT, which are commonly being administered and tried, and the results are a bit better than the older chemotherapies. And then for that, start with this type of the FLOT chemotherapy, and subsequently see how is the response to chemotherapy by repeating a scan, and then subsequently take the patient for surgery. Say for example, you have a disease in the stomach which are not gone to the lymph nodes per se, but you have smaller deposits all over the peritoneum. We can also do something called complete total peritonectomy, or the parts which are affected, the peritoneum is removed along with the stomach lesion, and do a HIPEC, that is called heated intraperitoneal chemotherapy. So this is something which is in a new form of therapy which is being tried, and it's too early to say, but at least we have some form of treatment in case the formal chemotherapy doesn't act. You heat the chemotherapy agents, and during the surgery itself you circulate that chemotherapy for 90 minutes into the stomach, and hopefully we look forward of curing or giving a long-term disease-free survival to these kind of patients. So once your surgery is done, what we typically say, there are two things which we often explain to the patients, is that you cannot eat a complete meal. You have to divide your meal into say for example, you have 3 meals a day. You have to divide your meals and make it 6 to 8 meals a day. Every 1 to 2 hours you might have to eat a smaller quantity of food, because your size of the stomach is drastically reduced. So to do that, you have to frequently start eating smaller quantities of food, whatever food you routinely take, and then subsequently your body gets adapted, and then it will take some time for your body to get adapted, and you get used to such kind of eating. And the other thing is, since we remove the distal part of the stomach, there will be vitamin B12 absorption is not going to happen. So we give vitamin B12 by injectable route almost on every follow-up to you. So once the surgery is done, send for the histopathology. Depending on the staging, more often not, the lymph nodes are affected, and patients present in advanced stage or third stage or fourth stage and early fourth stage, and many patients need adjuvant therapy, that is in the form of chemotherapy plus or minus radiation. Say for example, the lesion in the upper part, that is of the stomach, or at the junction of the food pipe and the stomach, that is the gastrointestinal junction. There are two forms, two types of therapy which has to be, like for example, you can either treat it with chemo plus radiation, reduce the size of the lesion, and subsequently operate such a case, or do chemotherapy 3 to 4 cycles and reduce the size of the lesion and operate. So in case of advanced stages, it always becomes difficult for radiation oncologist to administer radiotherapy after the surgery, and the tolerance of the patient also after surgery becomes difficult to administer radiation after surgery. So whenever radiation is contemplated, it is always better to give radiation first, then reduce the size of the lesion, and subsequently take up the patient for surgery. So you have your lifestyle modifications. So these are I'm telling you, this is the common cancer, that is adenocarcinoma, which see in the stomach. But there are also other types of cancers which are often seen which are not very common, but can be detected in the stomach. That is the lymphoma, which occurs in the lymphatic islets of the stomach, and the pretreatment completely changes. That's why it is very important to have a biopsy and to know what kind of cancer it is. So lymphoma per se, we treat it with chemotherapy plus or minus radiation in a subsequent, after the chemotherapy, if there is any residual disease, then we can add up radiation to it. There's one more cancer which specifically you can call it as a tumor. It is called gastrointestinal stromal tumor, that is a GIST. Which occurs, which is commonly seen in stomach, it is commonly seen in the small intestines, and rarely seen is in the food pipe or the rectum, that is where stools. So this again is treated with surgery and simple tablet or immunotherapy it is called. Thank you very much.